Hi everybody, welcome to our second lecture. Today we will talk about respiratory system. Just to remember, let's talk about the anatomy of the respiratory system. You remember, in this case we have two lumps. Okay, you know, right lump and left lump. We have two features: the horizontal feature and the oblique feature. Okay, so that means we have two features in the right and one feature in the left. Also, we have three lobes in the right side and two lobes in the left side. So also we have 10 segments in the right side and 8 segments in the left side. So apart of that, of the lamps, you have to look at the mediastinum with the heart and the trachea in the middle, and then you have to look also at the diaphragms, ribs, the liver, the spleen. You have to look at the stomach, in general the clavicles and the soft tissues. It's very important to know just to complete the sum of the respiratory system. So what kind of studies we can perform in the respiratory system? So first of all is a chest X-ray, common chest X-ray, plain film. Second, ultrasonography, fluoroscopy, CT scan, MRI, and also imaging and guided interventional procedures such as biopsies and fluid drainage. So apart of that, we are going to know right now the general principle to read any type of X-ray. General principles to read any type of X-ray. So we have 5 general principles which are very important for you. You have to follow this in this order. Any X-ray you are going to read, not only chest X-ray. So first you have to read the X-ray yourself. That means you have to be in front of the X-ray. Maybe in the monitor, maybe in the view box, where you have to be in front in the X-ray, not behind somebody or behind any doctor, behind any student. You have to be in front. Okay, you have to be systematic. You have to serially compare, observe symmetry, and believe you missed a finding. So it's very important. Read the X-ray yourself. Be systematic. Serially compare. That means compare both sides you have. Observe symmetry, and believe you miss a finding. So in serially compare, sometimes you have for instance, on trauma of the right ankle. You have any doubt, so you can request for the left ankle as well. So you can compare both ankle and look at if there is any difference between them. Okay, in case you have any doubt, you always have to believe you miss a finding. So that means you have to read the X-ray at least 3 times. At least 3 times from different angle, different distance. Okay, from different angle at different distance. Read the X-ray is the most difficult thing for any radiology or doctor. Chest X-ray is very difficult for any radiology or doctor in general. Okay, it's very difficult, so you have to take this in seriously. So a part of the general principles which you have to apply to or any type of X-ray, so you have to also take in consideration to today advice about how to read a chest X-ray. So remember, apply that principle and then to this general or the how to read an X-ray. So when you want to read the chest X-ray specifically, first you have to check the info on the request form. You have to check the info on the request form. Second, you have to evaluate the position of the X-ray. Third, you have to evaluate the technique. That means inspiration, penetration, and rotation. Fourth, you have to examine soft tissues and bones. Soft tissues and bones. You have to evaluate structures like diaphragms, trachea, hilum, heart shadows, and you have to evaluate lung pathology last. Evaluate lung pathology last. Okay, so remember, you have to apply this general principle with X-rays, and then you have to read this principle. It's very important for you to know. You have to read all these principles specific for chest X-ray. Okay, so first, check info. It's very important. You have to look at the position, but we are going throughout of all this technique. Evaluate the technique, inspiration, penetration, and rotation. Examine the soft tissue and bones, and evaluate structures. And evaluate lung pathology last. That means you have to read the X-ray from outside to inside. From outside to inside. So first you have to look at the muscles and soft tissues, then bones, then extrapulmonary structures, and then you go to the lung pathology. When you go to the lung pathology, you have to look at the lung. So you have to apply the general principle. You have to serially compare to be an order for that. So you have to be comparing the both sides of the apex lobe, middle side of the lung, and inferior part of the lung, comparing both sides at the same time. In that order, you can start from top to down or the down to top. That is your preference, but always comparing both sides. It's very important for you to know that. It's very important for you to know that the lung pathology is last. Okay, it's very important to know. So let's go to start with the prescription form. This is a general prescription form from Ghana Health Service. Okay, you are able to find this in any hospital. So first we will have a name of the patient, the age, the war. This is very important. Brief clinical history of the patient. So you have to, based on your physical examination, your finding physical examination, you have to briefly write the clinical history of the patient and your impression. Your impression. The meaning the patient have pneumonia. Let's see, we have they have pain in the right side of the lung, in the right lung. They have fever and is coughing. Your impression, right pneumonia, and then radiological investigation, chest X-ray. Then your signature, and the rest is for the X-ray department. Okay, that's the proper way to fill this to fill this request form. Okay, it's very important. Brief clinical history. That means you have to know the sign and symptoms of the patient, and you have to perform the physical examination and then give you your impression. Okay, and then request for the chest X-ray, because based on your clinical history we give you the diagnosis. We're going to give you the diagnosis because there are plenty similar diseases. What is different is the signs and symptoms of the disease. So for signs and symptoms, you go to study this one the next year in your clinical phase. Okay, in the clinical phase. So that means you want to apply all of this knowledge from next year with the patients when you arrive to the clinical phase. But remember, first you have to know the sign and symptom of the patient, and then the radiological study you want to perform on that. Okay, it's very important to know that. Then let's move on. Now let's go to talk about the positions. So we have 4 major positions. Okay, in the X-ray, in the chest X-ray: posterior anterior position or PA, lateral anterior posterior position or AP, and lateral decubitus. Remember, there are 4: posterior anterior position, lateral position, anterior posterior position, and lateral decubitus. So let's go at the sample of the position here. In the left side, you can see this is a chest X-ray where the cardiomediastinal contour is significantly magnified. This is the anterior posterior position, such as when the patient is unwell in bed, the heart and mediastinum are distant from the cassette. So this patient coming on the bed to the X-ray department, they are too distant from the cassette. They don't have the exact distance. We requested to get a good magnification of the heart and mediastinum. So for that reason, in this case, the cardiomediastinal contour is enlarged, is magnified. Okay, so you can see is this in your right is the same patient. Just this one was taken with the patient posterior anterior position. Okay, in posterior anterior position. So the patient stand up in front of the cassette. You want to see that in your practical area. You want to see how to perform a chest X-ray properly, so you know a general idea about that. Anyway, you have any doubts, you always go to YouTube and look at any video how to perform a proper X-ray. Okay. So this is just the same patient taking one only 1 hour later. We're thinking the patient have any disease on the heart or maybe in the aorta, but we just realized it was supine, and then we look for the normal chest X-ray in erect position. Okay, so the patient is standing in front of the X-ray like I say, close to the cassette, the correct distance, and they back to the radiographer. You can see there is no cardiomyastina magnification at all. So this is a normal chest X-ray. So it's very important to know the position of the patient. Okay, it's very important to know the position of the patient. Then let's go talk about lateral position of the patient. This you can see it's very important the lateral position of the patient. The costophrenic angle. Costophrenic angle are down here. You compare with the anterior costophrenic angle. For the reason when you have any small perfusion, you always have to request a lateral X-ray if it's not visible in the anterior position. This is a lateral decúbito. This is a lateral decúbito X-ray. In the arrow is we have a pleural effusion. Pleural effusion. Okay, we will talk about more in our next slices about that. Now let's go to start talking about the technique in your let's talk about the inspiration. So we have these two X-rays from the same patient. The X-ray number 1 is an example of poor inspiratory effort. You can see the only 4 complete anterior ribs are visible. This results in several spurious findings like a cardiomegaly, that means the heart is enlarged, a mass in the aortic arch, and patchy opacifications in both lower zones or both lower lumps. So this X-ray, the X-ray, 1 hour later the X-ray was taken again with a good inspiratory effort. You can see in the X-ray number 2, all the findings just disappear. So there is no more cardiomegaly, there is no more aortic arch aneurysm, there is no more any patchy opacification simulating any kind of pneumonia. So for that reason, it's very important to know the quality of the X-ray, in this case inspiration. Now how you know the inspiratory effort was done or was good or not. So you just simply counting the ribs, just like that. You have to count the ribs. So in any X-ray you want to see, you have to see at least 6 anterior vertebra, 6 anterior ribs and 10 posterior ribs. 6 anterior ribs and 10 posterior ribs. Remember, we have only one the complete ribs. We have posterior arch and anterior arch of the ribs. Okay, so we have to look at the 6 posterior arch at least, and 10 anterior arch of the ribs at least. It's very important to know that. So you have to scrutinize every rib. Okay, just not looking only for fractures, just count the ribs and look for the good inspiratory effort. So let's go talk about the penetration. So in a proper X-ray, the lower thoracic vertebra should be visible through the heart. The bronchovascular structures behind the heart to be visible. Okay, that's a very important note. You have to always be sure about that. You can look at the arrow. Okay, so now when we have a X-ray without no proper penetration, in this case on the sposa, that means the radiation dose was too low. Okay, was not enough. So when these things happens, the cardiac shadow is opaque, it's more opaque than usual, with a little or no visibility of the thoracic vertebral bodies. The lungs may appear much denser and whiter, much as they may appear with the infiltrated cell present. That's very important to know on the exposure. Now our exposure. Our exposure is when the dose of radiation used in this case was too high. So in this case, the lamps become extremely radiolucent and often give the appearance of lacking lung tissues. So similar to a condition we call it emphysema. It's very important to know the exposure or the penetration quality. The other thing of the quality of the X-ray is to look at the rotation. Okay, in your left side you can see it's a normal X-ray. In your right side you can see this a rotated X-ray. So you can see how the different are these two X-rays. So patient rotation can be assessed by observing the clavicular heads and determining whether they are equal distance from the spinous process for the thoracic vertebral body. It's very important to know that. Okay, otherwise they want to appear spurious findings in the X-ray. So remember, you have to look at the inspiration, penetration, and rotation on the X-rays. So, multiple doctors they are treating pneumonia or other kind of disease is thinking the patient thinking the X-rays is positive. Okay, but as a matter of fact, there is no a good technique of the X-ray, and they don't know about that. So you have to know very careful with this. Okay, you have to know very careful with this. You have to know very well when the X-rays is done in the proper condition and the proper quality. It's very important to know that. When you look at the X-ray, you have to be aware of the both costophrenic angles. Okay, remember the right is higher than the left. You know that because of the liver. But you have to look at the outline of both diaphragm very well. Okay, and then the hiding zones. So hiding zones are behind the liver and the spleen, behind the heart, and also in case of lucencies in both apex of the lungs, in both apex of the lungs. Okay, so any cavitation can be hide in the both apex of the lungs. Okay, so you have to be aware of that. Sometimes you have a patient with signs and symptoms, maybe pneumonia or other type of disease, and when you look at the X-ray is negative. So you can think about maybe it's behind the heart, maybe it's behind the it's not visible because of the liver or the spleen. Okay, it's very important to know that. You can request a lateral X-ray in this case. Now, why would you order an X-ray? Why would you order X-ray? So you order X-ray because of the symptoms. Okay, maybe it's about persistent cough, chest pain, chest injury, coughing out blood, fever, shortness of breath, or fall, and many more diseases. So let's talk about opacities. Today we're talking about opacities. Remember, opacities is coming from opaque. Now remember that opacity is coming from opaque. We have different type of opacities. So we have these patterns of opacity. We have consolidation. Consolidation always majority of the times means infection. Okay, so you can talk about opacity, also consolidation. We have interstitial pattern of opacities, nodule or masses, and atelectasis. And atelectasis is the full pattern of opacity you have to know to make your differential diagnosis very well. So let's go to talk for the first infection today is pneumonia. So pneumonia is a very common disease. You want to know that from your next year. It's a very common disease. You want to see a lot of patients with pneumonia. So what happens in pneumonia? Usually we find an opacity. Okay, so you can see in your left side there is a right upper low consolidation. Okay, right upper low consolidation. This consolidation contains 8 bronchorams, which is a tubular outline of an airway made visible to the filling of the surrounding alveoli by fluid and inflammatory exudate. This is a classical sign for pneumonia. It's very important to know that. Maybe I can appear in another diseases. Sometimes cancer can also do produce that kind of images. So you can see in the left, in your right, the right middle of consolidation or opacity. The right middle of pneumonia. These are other examples for pneumonia. You can see they are always opacity. They are always opacity, okay, or consolidation. You can call it as well. So now, because we have in this pandemic now, coronavirus, the kind of coronavirus, these kind of things, I draw just this example in case of the triage of any suspected patient with coronavirus. So the first thing you have to know, to request the chest X-ray, the patient has to get the moderate to severe clinical features, okay, moderate to severe clinical features. With a higher probability of the disease. Okay, you can see there is in the arrow this all opacity through both lamps, all these kind of opacities through both lamps. You can see that this in chest X-ray is very specific, but mainly the opacities are bilateral. Okay, are bilateral in both lamps, like you are seeing this both rays. So any patient you are seeing during this period with these opacities and fever, always think in COVID-19. Okay, it's very important for you to know that. Let's continue. And our opacities, we have in this case a pancreas tumor. The pancreas tumor is a frequent tumor and it's very aggressive. I brought this in this presentation because it's very aggressive, and you have to know that. You have to know that it's very aggressive, and you have to be aware of these tumors. You always go to appear in the upper lobe of the lumps, maybe right or left. But it's very aggressive tumor where you have to take in consideration. Sometimes the patient didn't come with any respiratory symptoms. Okay, just coming with back pain or maybe shoulder pain. When any patient shoulder pain or back pain, the physical examination negative, always think you need tumor and request your chest X-ray. Another type of consolidation or opacities, we have Goethe. In this case, you can see the superior mediastinal mass extending to the neck. Okay, it's very important to know that. Remember that. This is another example on your right, a malignant Pneumonia. See all the opacities with metastasis in this case. This is an example of opacification, the opacifications. Now the also example of opacification is Cannonball metastasis sign. You can see there are multiple nodules and masses in both. They are quite big in both lumps. This we commonly call Cannonball metastasis. Okay, and then another example of more metastasis in your right side. So it's very important to know this kind of thing. Now let's talk about that lung collapse or atelectasis. Lung collapse or atelectasis. So atelectasis can affect the whole lump, a single lobe or a segmental component. The lobar collapse are important not to miss on imaging. They may be associated with an underlying malignancy. So it's very important to know in every atelectasis you have to suspect first malignancy. Okay, always suspect any type of cancer. So you can see on your left this opacity in your right upper lobe. Okay, this opacity atelectasis in the right upper lobe. You can see right medial lobe collapse in the lateral view. Then opacity, you see that triangle here, and then this is another type of atelectasis, but this is a total atelectasis in the right lung. It's a total atelectasis in the right lung, second to a complete obstruction, okay, of the right bronchial, due by carcinoma. Due to carcinoma, okay? So it is complete obstruction of this big main bronchial This produces there is no air flowing in or out, and the lung collapse. So what happens? We have this kind of diseases. In this case, the mediastinum, like the arrow is indicating, is shifting or pulling to the anoma side. It's very important to know that in atelectasis, the mediastinum is pulling or shifting to the anoma side. It's very important to know that. Okay, you can see in your left this another total lung collapse because the incorrect sighted or the endotracheal tube, incorrect sighted the trachea tube, the total lung collapse. You can see the mediastinum in this case pulling or shifting to the left, okay, because the bronchial, which is obstructed, is the left in this case. So the mediastinum is shifting or pulling to the anoma side. It's very important to know that. Keep that in your mind, okay? Now we talk about parafusion. Parafusion, we find also opacity. You can see in the right and your face on the left, the right parafusion. This is opaque density, okay, which is standing from the base with a meniscus shape. This on your left, opaque surface. You have to review what the meniscus sign when CXR later. You have to review that, okay. Now on your right, we have loculated, big loculated parafusion. You can see, which is pushing the mediastinum to the left side, that means to the normal side. When we have a huge pleural effusion, moderate to severe pleural effusion, the mediastinum is pushing to the normal side, or if shifting to the normal side. Okay, so you know the same thing of total atelectasis. Remember that in this case, mediastinum if shifting to the normal side, okay, or pushing to the normal side. Okay, it's very important for you to know that, to be very clear, because it's technically the difference between atelectasis and a massive pleural effusion. And you're going to be leading almost every day with this kind of diseases. This is a sample of small pleural effusion. You can see in both costo-phrenic angle are not visible. Otherwise, when you like I said, when you have suspecting a pleural effusion and the costo-phrenic angle look clear, you can request a lateral CXR, depending on the side, maybe right or left. Remember, because the costo-phrenic angle, the posterior side is more lower than the anterior side. Okay, so you can request your chest X-ray or lateral chest X-ray. And this is a sample of infarction or pulmonary embolism. It's very common to treat the here in Ghana, to treat this kind of diseases. Even they are very uncommon. Okay, they are very uncommon. When any patient arrives to the emergency room, they want to treat cardiac infarction or embolism at the same time. But it's very difficult to do the diagnosis of pulmonary embolism. Okay, mainly go to appeal opacity. This cavitation, you can see there is a cavitation there, but it's very difficult. I just bring to the table just to let you know it's very difficult to do this kind of diagnosis. Okay, it's very difficult in any hospital. It's very difficult. Then let's move on. We continue with this foreign bodies. You can see there is a fish bone in the arrow in the hypopharynx anterior to CC. So it is a fish bone for sure. You have to be careful when you are eating your tilapia soup. Okay. The other thing, this case is for tamale. You see this is baby swallow like a metallic coin. Okay, it's projecting the superior part of my tongue. You see this one are very easy to localize and see. Now, but what happened here in Ghana? You know, the people, they eat a lot of granules. Even small children, they are eating granules a lot. And the parents just give it to them, and sometimes they don't take the correct precautions, and they can hear the granules. What happened? These granules were going to be go direct to the right main bronchus, main bronchial. Go direct to the right main bronchus. Why? Because the right bronchial is more vertical than the left. It's more vertical than the left, so we always go to the right side. They want to put there. They want to produce difficulty in breathing. In the majority of the cases, the X-ray is negative. The X-ray is negative at the beginning. So what happens in this case? You have to follow the patient. You have to admit the patient in the emergency room. So you have to follow the patient with chest X-ray. What kind of chest X-ray? So you take you want to take the technician to do one X-ray in inspiration and another in expiration. Because what happens with these granules when they are stuck in the right main bronchus, they go to produce a ball valve. Ball valve, that means the air coming in but cannot coming out. So that lung go to appear hyperinflated, and also it will be like a pneumonia in the majority of the cases, because the secretion cannot go out, and then they produce some kind of infection in the right lung. Okay, so you always have to put attention to that. Okay, so now let's continue talking about this case about respiratory lucencies. Remember, lucent or lucency. So our first disease, which is very common, is asthma. I know you hear about this kind of disease. What happens in this disease? The blood lungs should be hyperinflated. There is a bilateral diaphragmatic flattening with 7 anterior vertebra, with 7 anterior ribs and 11 posterior ribs minimum. Okay, in case of asthma attack. You will know the clinical features anyway. It's wrote here, but you will know the clinical features from the next year. In this case, the asthma, you have to be aware. If a very known patient, first you have to treat the asthma before you send to X-ray. Okay, so first you have to stabilize the patient, then send him to the X-ray just to confirm your diagnosis. Remember always that. Another kind of disease, but in this case, the all patients is a chronic obstructive pulmonary disease. Chronic obstructive pulmonary disease is similar to asthma, but in this case, you go to appear some parenchymal lines simulating fibrosis, and in the lateral view, go to appear this barrel shape, due to a barrel shape sign due to increase of the retroexternal air space. Okay. It's very important to know that. Remember, this is an orientation class. You can pause the video whatever you want. Anyway, you have a PDF with all this information. The results are going to attach another information for this matter. And then also assignment. Remember that to check. All the assignment you go to get and the extra information you go to get in the website. The other thing is, if you have any doubt, remember you can Google. Okay, you can Google, go to YouTube and find explanation. Remember, this is only orientation. Okay, orientation. And say, I also making emphasis in the important thing you have to know to be very clear. The rest you have to also important, but you have to look for them in other sites, okay, YouTube or Google, like I say. So another disease you ought to see your career in the entire life is emphysematosis bulla. You can see is where demarcated. You can see the arrows there. You can see that central area. There is no pulmonary tissue. That one is only A. Okay, it's very important to know this one, because in case this bulla broke, explode, go to produce a serious pneumothorax. Serious pneumothorax is very important to put that in your mind. Now another pathology is abscess. So what happened in the abscess? In the abscess, you compare with the bulla. You see the bulla, the walls of the bulla are very thin, and there is no airflow level. In the abscess, the wall is thick and there is airflow level. You can see with the red point the fluid, okay, with the fluid, and with the blue point the air. Remember, remember fluid is opaque. Okay, it's opaque, and of course air is lucent. So that we call it a fluid level, air fluid level. All right, and the difference between this one and the bulla. The wall of the abscess is thick and the bulla is thin, and we have a fluid level in the abscess and there is no a fluid level at the bulla. Okay, it's very important to know that the abscess can be single or solitary, or can be multiple at the same time. Okay, now this let's go talk about pneumothorax now. Pneumothorax is accumulation of air within the pleural cavity. Okay, we have three types of pneumothorax. Has a simple pneumothorax, which just you can see here the parietal with the complete arrow, the visceral part of the pleura, with the lump with this partial collapse, and it's also pushing or shifting the mediastinum to the normal side. It's pushing or shifting the mediastinum to the normal side. It's very important to know that. Another type of pneumothorax, tension pneumothorax. So tension pneumothorax is very important because this one can kill the patient. Okay, remember, pneumothorax can be after trauma or also can be spontaneous. Everybody can get the pneumothorax. Okay, so in case of pneumothorax, this one can kill the patient. So you are suspecting tension pneumothorax and you are in the medicine, first treat the patient. Second, after when the patient is stabilized, remember sending to for the X-ray to confirmation. But first you have to save the life of the patient, otherwise the patient can die even taking the X-ray or before arrive to the X-ray department. Okay, those are very important. Now you can see here, you can see there with the arrow that the lung collapse. You see, it's very small. The red O is A. Okay, you can see the mediastinum is also pushing to the left. It's a normal side. Okay, there is no pathology on the left. You see it's pushing or shifting to the left side in this case. Okay, that means the mediastinum is go far from the pathology. Okay, and remember it's an emergency. The other type is barotrauma. So barotrauma is also a type tension pneumothorax. It can be very frequent in the ICU. Okay, in the ICU you can see here very clear the lung is partial collapse and it's pushing the mediastinum to the left side. Okay, that means to the normal side. Okay, so it's pushing or shifting the mediastinum to the normal side. It's very important to know. We have diseases like teleptasis, pleural effusion, pneumothorax, which you have to take in consideration when the mediastinum is going. Okay, to which side the mediastinum is going, is pulling or is pushing or if shifting to which side. That's very important to know. You have to put that in your inside of your brain. Now let's go to talk about this common disease, tuberculosis. This disease is very common. It's everywhere. More here in Africa, more here in Ghana, we have a lot of cases of tuberculosis. Not only for the chest, we have spine, the joints, intra-abdominal tuberculosis is like a plague. It's everywhere. Okay, so it's very important for you to know this disease. So we have these features of the disease. So we have three main types of pulmonary tuberculosis. We have primary, post-primary, and miliary. This in your slide the sample of miliary tuberculosis. You can see this is bilateral, multiple tiny nodules scattered throughout both lungs. It's very important to know that this is a sample of miliary tuberculosis. Also, we have primary TB. In the primary TB, everything we're going to see is paratracheal or parahilar adenopathies. Paratracheal or parahilar adenopathies. Just in post-primary TB, we're going to see fibrosis, opacities, retractions. You can see in this case in both upper lobes, with fibrosis. This is a sample of chronic TB. Now this is another sample of chronic TB. You see in both apex, apex of this lamp, this type of cavitation. We have a lot of cavitation here. You can see it over there. Or this huge cavitation on the red cell fibrosis is there's a very frequent on TV. So you have to pay attention to that every time you can see this one is for sure is TB. Okay, so what happens with this cavitation? It can get infected and become in abscess. It can be infected and become in abscess. It's very important to know that. Now let's move on. This is another disease, bronchiectasis is just dilatation of the bronchial. Okay, it's very common disease. The patient also gets infection very easy, and you have also to pay attention to the disease. You have to review this disease and the radiological features as well. Now, just finalizing, I want to talk about this. Also, we can have a traumatic diaphragmatic hernia or congenital diaphragmatic hernias in this case. Okay, you want to see like a lucency of the bowels in the lamp. This will talk more about next year in your 4th or 5th year. We have also a presentation for I will do a presentation video for chest trauma, where all this should be next year with all disease you have to know when you pass by surgery surgery rotation. So so far this is all for today. Remember to review again everything past the video. Check the complementary the additional resources we are going to add to this second lesson. Remember, you have to know the general principle of the X-ray, which you have to apply to any X-ray you are going to read. Remember how to read the chest X-ray. Remember, you have to read first the prescription of the X-ray, the request form of the X-ray, a brief history of the X-rays, type your impression, then the type of the X-ray. You have to know the position of the X-ray. Then you have to check the quality of the X-ray. Quality of the X-rays. Then remember to start from outside to inside. So you check first extrapulmonary structures. So first you have to check the soft tissue and bones. Okay, and then you go inside. You have to compare both sides. You always do it in order. Okay, the other thing is very important. You have to know about atelectasis. And pneumothorax or perfusion. That's very important to know. Also pneumonia, but that's very important to know because for the position of the assignment you have to put that one in your head as well. Okay, so that's all for today. Now I see you in the next lecture.